Welcome, everybody. My name is Paul Kent. I'm a pediatric oncologist at Rush University Medical Center in Chicago, Illinois. It's been my privilege to take care of patients with fibrolamellar for the last 4.5 years. It's our hope that today we can offer some preliminary but promising results on a new therapy to help those most difficult to treat patients, those patients where surgery is not an option or they've had multiple relapses. The title of my discussion today is from a recently published poster entitled Gemcitabine Oxaliplatinum Lenvatinib, or GEMOX-LEN for unresectable fibrolamellar carcinoma, promising results in our first 16 patients. So first, a little background. As most of my audience knows, fibrolamellar is extremely rare cancer, and therefore there's very little data. Ideally, the data would be randomized controlled trials. However, those take a long time to come in to get enough patients and to really be able to tell what's working. In the interim, we have to have some treatment options for patients who don't have any treatment options or who there is no standard of care. With this understanding, we tried for the first time this combination approximately 2 years ago on a young woman to whom this talk is dedicated, named Sophia Schatz. She had tried many of the usual options for fibrolamellar carcinoma, including 5-FU and interferon immunotherapy. She'd had multiple surgeries. She'd had radiation. She'd had ablations. Her tumor, unfortunately, had spread. So using the guidance of the Children's Oncology Group study that has a brief 2-cycle therapy specifically for fibrolamellar patients using gemcitabine, oxaliplatinum, and sorafenib, we decided to change the sorafenib to lenvatinib for 2 reasons. Number one, in head-to-head studies, lenvatinib has repeatedly been superior to sorafenib in its efficacy, or in some cases non-inferior, but it's always been equal or better in terms of efficacy. And certainly in terms of side effects, it's shown far fewer side effects, which has been true in my personal experience as well. Secondly, the combination of these make sense. The chemotherapy approach of killing cancers at the same time depriving the cancer of blood flow, which is what lenvatinib does, and blocking some of the key pathways that are important in fibrolamellar, which is the second reason we wanted to use this instead of sorafenib. It blocks more targets and more pathways that we know matter. Our first patient started off with just the GEMOX by itself and had no discernible response. We encouraged the treating physician to add the lenvatinib, and after appropriate consent and approval by the family and by the local IRB and hospital, it was added. There was a dramatic response seen within just 4 weeks. The patient reported feeling better within 2 weeks. We continued on with this for 10 more cycles on our first patient. Eventually, she was able to have surgery and have all her residual cancer removed. Unfortunately, the cancer did return later, and she was no longer able to get the GEMOX-LEN. However, it did show us that this combination could work. So our report here today is from a 2-year experience, from tax day, April 15th, 2019, till April 15th, 2021. And in that 2-year period, we treated 19 different patients with the GEMOX-LEN combination. 16 of them we could evaluate. The 3 we could not evaluate, one passed away very soon after starting the GEMOX-LEN from a stroke. We do not know if it was related or not related to the therapy. The other 2, it was too soon to evaluate. We wanted to make sure they'd had at least 2 cycles of therapy and re-scanned. Of these 16 patients, on average, they'd had 10 cycles of this combination chemotherapy. All of them were metastatic when they started, and all but 3 of them had already relapsed at least once. The majority of the patients, as you can see in figure 2A had previously had either GEMOX alone or lenvatinib alone. And I make this point because we think it's the combination that matters, and that using the pieces of it is not likely to be successful. And furthermore, if the pieces don't work, it does not mean the combination will fail. So in this particular diagram, we're showing these 16 patients and how much their tumors shrunk. On the left side of the scale, it shows the percent change in tumor volume. The first one on the far left says minus 100%. That means all visible tumor had disappeared. On the far right, there is a patient where it showed perhaps a slight increase of 2%, although it's too early to say. In oncology, because small changes occur, we usually use a cutoff of minus 30% to say there's been a partial response, or plus 20% growth to say that it is a failure. And everyone in between is considered stable disease. By these criteria, all of our patients had either a partial response or stable disease. 60% had already a partial response, and many of them are continuing to respond. The second graph, figure 2B, shows how long these responses have continued. The green lines are people who have had at least a 30% decrease in their tumor and are considered partial responders. The yellow lines are the ones who have had stable disease. Most of these patients are continuing as indicated by the arrow. There are 2 patients that stopped. One of them stopped because they got to the point where they could have a big surgery. Another one stopped because of very rare side effect thought to be from this treatment. Next, figure 1 are some examples of the tumor shrinkage. These are 4 different patients, and comparing the left side to the right side, in other words, A to B, shows how much the tumors had shrunk. Lastly, the side effects. Figure 3 shows the side effects that were found. Toxicities of any level are listed in the first column, and toxicities of grade 3 or 4, meaning that you'd either have to hold the treatment or stop the treatment, depending on how severe, are shown in the right-hand column. The most common side effect was allergic reaction to oxaliplatin. For people who had an allergic reaction to oxaliplatin, all were treated successfully and had the allergy reversed. However, 2 of them required admission to the hospital. Subsequently, those patients switched to a similar drug called carboplatin from the oxaliplatin and has continued to have excellent response. The one patient who had to stop because of toxicity is second from the bottom in figure 3, is a TTP-like illness. This is an illness that can look sort of like COVID or even DIC in its worst case. Thankfully, it was caught early. The kidney impairment quickly fixed itself and everything else quickly fixed itself. We don't know if it was from this treatment, but it was serious enough that we thought it was the safest, most prudent thing to stop. Ultimately, our goal, however, is to use this as a bridge to surgery. So of our 16 patients coming in, only 2 of them were considered surgical candidates, but both of them considered to be very, very difficult surgery. At the time of this publication, 5 patients have gotten to surgery and had a definitive surgery and back into what we would call a surgical remission. The disease response, meaning all the people in remission, all the people with a partial response, and all stable disease, was 100%. At least to date, we have not had any failures. The objective response, meaning where it was clearly shrinking the tumor, is 53%. My experience has been that, especially for younger patients, they do very well with it. Most of them, it's outpatient. They don't have undue side effects. However, we do have to have special attention to nausea from the oxaliplatin and neuropathy also from the oxaliplatin. And we treat this proactively and do everything we can to prevent it from occurring in the first place. Thank you for this opportunity to present our preliminary data. Be happy to answer questions or talk to any of you. My email and contact information is on the website, and I look forward to being able to publish this work in a paper with now 22 patients and more up-to-date results. Mostly, I want you to know, don't give up hope, that while we wait for the final, most definitive data to come in from randomized controlled trials, You are not without options and definitely not without hope. Thank you.